Hello, friends. We're talking on this topic, approach to difficult weaning. So, I'd given this talk as part of a ventilation workshop in Hyderabad. So, I wish to acknowledge my colleague, Dr. Pradeep, who helped me develop this content. It's an important topic for all the trainees, and it's good to have a bit of a clarity on this approach to weaning. So, when we talk about weaning, there are few steps. So, the first one is to ascertain that the underlying condition is treated and patient has recovered. Suppose if someone has had a pneumonia, they have recovered from pneumonia and recovery process has been established. So, that is the first step. And then one needs to check if the patient could be put on a weaning protocol, determine whether he or she can go on a weaning protocol. And most important, this is the thing that possibly every trainee has to pay attention is to look at the checklist, whether they fulfill the criteria for weaning. And then you determine whether you would want to put the patient on spontaneous breathing trial or a TPs or pressure support ventilation as a weaning mode. And then you determine whether patient can be extubated. So the key element is post extubation. There are two possibilities. One is they can fail extubation, or it could lead to successful extubation. But our whole effort is to ensure that the failure of extubation is mitigated because multiple studies. This is a point every trainer has to be absolutely clear. When we do a weaning trial and determine the suitability for extubation, one has to be absolutely clear that the risk of failure is significantly less because the reintubation portends significant morbidity and has a bearing on outcome. So this is extremely important in ICU. Gone are the days where we say that okay, we'll give a trial of extubation because we see some other teams, like it may be surgical team or neurosurgical, where say anyway you extubate, if you fail, you can always reintubate and do it tricky. That should not be the thought of an intensive. Our whole effort should be to prevent failure of extubation because failure of extubation can worsen the outcome with regards to morbidity and mortality. So gone are the days, because I do remember in the past where such neurosurgical colleagues, they would say just extubate. If he fails anyway, we can just intubate. So that notion, we should take it out from our thought process in intensive care at this. So this is something I want to emphasize to all the trainees. So once you determine that patient could be weaned, so you look into two broad categories: the readiness testing and the actual process of weaning. So for the readiness of testing, one has to objectively look into the criteria that whether patient is fulfilling the extubation criteria, which means the underlying condition has been rectified, and whether the spontaneous breathing trial that you have put is been successful, and patient is neurologically fine, coherent, communicative, there is no neuromuscular weakness, so on and so forth. And then you put into the process of weaning. So weaning, there are different ways. So one is to reduce the support. So reducing the support come into two categories. So where you remove the full support, put them on a spontaneous breathing trial. Or the second process is we gradually tweak the support down. And this is something we tend to do often. So where we slowly reduce the PEEP, slowly reduce the pressure support the patient is on, bring them to 5 of pressure support and then extubate. So these are the two processes where from a controlled ventilation, you put them to a spontaneous breathing mode, or you gradually reduce the support and then you discontinue the ventilation. So this weaning process has shown to significantly reduce the morbidity, mortality, and even the cost for the patient because you would minimize the duration of weaning. And having this weaning protocol is a quality indicator in ICU, and at least more than 55% of the ventilated patient in ICU should be assessed for the weaning and should be subjected to some sort of a weaning protocol. Is the uh, so is the sort of a standards that one needs to maintain. So choosing a weaning method, so there are three broad categories. One is a spontaneous breathing trial. The second one is gradual reduction of pressure support. And the third one is gradual reduction in ventilatory assisted breath. So the most studies have looked at which is the best way of weaning. And studies have compared between spontaneous breathing trial and pressure support. And most of the studies, earlier studies have shown spontaneous breathing trial is good enough, but we'll look into very briefly as to what is our current understanding. So once the patient is put on a weaning mode, be it a spontaneous breathing trial or reduction pressure support, so the weaning period typically is 30 minutes to 2 hours. We put them on pressure support of 5 to 7. So where you have gradually reduced the pressure support and brought them to pressure support of 5 to 7, and you see if the patient is very comfortable for at least 30 minutes to 2 hours, or put them on a CPAP. And if you are using a Puritan Bennett ventilator, there is something called automatic tube compensation. So you can use any of the modes. In my ICU, typically we keep the pressure, so we gradually reduce the pressure support. We keep them at around 5. They're able to tolerate for 2 hours. Then it is a clear indicator that there could be a trial of extubation that can happen. And once you put them on this weaning mode, either be it spontaneous breathing trial or pressure support of 5, so one obviously needs to look if the patient is different. Look at the heart rate, look at the blood pressure, look at the respiratory rate. Very often, like as I'm giving this talk, we have a patient in ICU. When you put on pressure support of 5 to 7, you would see gradually patient getting tachypneic at around 35. So that is definitely that's an indicator that she's going to fail. And when their accessory muscles are being used, this patient is extremely comfortable on a controlled mode, but when as soon as we put on a weaning mode, you would see that he's okay for maybe 5-10 minutes, and then you would see that slowly the tachypnea worsening. So this is a clear indicator that possibly there will be a failure. So we have to ensure that the heart rate, blood pressure, respiratory rate, and saturations are maintained at a physiological levels. Only when they are maintained comfortably for 2 hours, when you put them on a weaning at a physiological level, then the process of extubation is something that you can contemplate. And then you would call it as a successful weaning. But but if there is a failure of this, if patient gets tachycardic, if blood pressure tends to go up, or if there is hemodynamic instability with uh, escalating doses of vasopressors, or if tachypnea happens, or if there is some sort of desaturation, then there is a failure of weaning, and then one has to work up for what are the reasons for weaning failure. So this is an approach, although it appears very intuitive, very simple. Once you put them on a weaning mode, one needs to look at the physiological parameters and ensure they are at a physiological range. Even if they become tachypneic to 30 or and if there is a increasing tachypnea, if accessory muscles, then please do not extubate because they would fail extubation. And spontaneous breathing trial is shown to be effective, efficient, simple, and safe. So identifying, how do we identify weaning success? So just pictorially I put it. So keep this picture in mind. Even in exams, this weaning, so the weaning process or difficulty in weaning can be a question. So you can even use diagrams to represent your conceptual understanding of this whole weaning. So if patient is very agitated and restless, and there is no reason for that, so that one should have a concern that the patient may have a difficulty in weaning, and someone who is completely obtended or somnolescent, obviously weaning process is something that cannot be established. Or if blood pressure is very high, or if it is hypotension with increasing vasopressor, it should raise a concern that they could possibly fail the weaning process. As I've already mentioned, if there is tachycardia, if there is an unexplained tachycardia, one should ascertain the reason for it, and don't jump into weaning and extubation, especially if tachycardia is more than 120, 140, or more than 20% of the baseline. And as I've re-emphasized on this, if tachypnea is present with respiratory rate more than 35, definitely is the cause of concern, and you should not contemplate on weaning process and extubation. And PaO2 less than 50 millimeter mercury, or pH less than 7.32. So all these are a clear indicators that weaning process cannot be initiated, and one should be very cautious. And blood pressure, as I mentioned, hypertension and hypotension both are indicators that one should not contemplate on the weaning process. So deciding whether to extubate, as I said, patient should be conscious, should be comfortable, should be coherent. That's very important. And ensure that there's no thick copious secretions, because if patient has a very thick copious yellow foul swelling secretions, then very likely the weaning process may fail, and they may fail extubation, because the fact that they have a lot of secretions may be portending an ongoing infective process. And most importantly, in a patient with a stroke or someone elderly with Parkinson's, please look for cough reflex, because that is extremely important in ICU, because they may fulfill all the criteria. Patient may be on a pressure support of 5, and they may be maintaining all the vital functions in the physiological range with heart rate, blood pressure, saturation, respiratory rate, all being normal. But if there's absolutely no cough reflex due to Parkinson's or due to the stroke, they would fail extubation because they cannot cough and clear the secretion. So this is also a simple thing, and one needs to have an absolute attention to this with regards to cough reflex. So this is just a pictorial representation of how a weaning failure patient looks. He or she may be tachypnic, using accessory muscles of breathing, or look for the nasal flaring and look for accessory muscles of breathing like sternocleidomastoid, so on and so forth, and intercostal recession and tachycardia, tachypnea, hypertension, or hemodynamic instability, or all of the reasons which indicate to you that they may feel bleeding, or even a simple pain which may not be controlled. If patient is in severe pain, severe anxiety, all this can lead to weaning failure and extubation. So when it comes to difficult weaning, there are certain clear indicators. When the first spontaneous breathing trial fails, so the first separation attempt, what you do, spontaneous breathing trial. So you put for 30 minutes to 2 hours, and patient fails extubation, then the possible need for subsequent spontaneous breathing trial up to 3 times or up to 7 days may be needed for successful weaning in 26 to 39 patients, which means to say, if your first attempt of weaning has failed, very likely it is an indicator that the subsequent, it may take up to 7 days and 3 subsequent trials in up to 40% of the patients for successful weaning to happen. So this has been shown in the studies. And if weaning attempts and successful weaning has taken more than 7 days, it means there is increased risk that has a bearing on increased risk of mortality and extubation failure. So, which means if you have failed the weaning process for more than 7 days, it tells you that very likely they will fail extubation and it has a bearing on mortality and they may fail extubation. So, this is a very important thing, and I'll show you the study where this has come from. And more than 7 days, if you have failed your weaning attempts, then obviously the patient possibly would need tracheostomy um, and the care post tracheostomy for successful sort of a weaning. So the difficulty to win, there is something called wind classification. There was a big sort of a wind study that happened in the France, and this was published in American Journal of Respiratory, where they looked at a big database and they have determined certain cues to determine and put them into 3 different categories with regards to weaning failure. So group one is where you put them on a weaning protocol and they succeed, and that is the best thing. So there you extubate, they do good, and it's a successful sort of a weaning. That is group one. Group two is where first attempt has failed. They come into the second category where more than 3 attempts may be needed in the next subsequent 7 days. And you possibly would need from day one to day seven for successful weaning to happen, and they come in the group two. Group three is more than 7 days. More than 7 days, you have failed to wean, and it has taken more than 7 days. And that is where possibly the indicator is that they would possibly need tracheostomy for further weaning from the ventilation. And why this is important is this wind study has shown that there is a linear correlation with mortality with delayed weaning. So this is an important message that came out of this study. So this was the study that came, epidemiology of weaning, the WIND study. So very important study where they looked at a large database of 2051 patients, and they've done first separation attempt and seen if this success. Like patient is ventilated for 3 days, then they put them on weaning. So the first separation attempt is successful. That is the best. If you see, it is 0 days. So the duration of mechanical ventilation in this group was 3 days, which means at the end of 3 days, they put them on a separation attempt or the weaning protocol, succeed and extubate. Grade, the group two is where they have exceeded 7 days, mechanical ventilation of 9 days, and they took 3 days for the weaning to happen. And group three is patient was prolonged ventilation for 19 days and it took 11 days, which comes into basket three or category three, where more than 7 days it is exceeded for them to be. Why this is? Then they looked at outcome of this patient. So if you look at the mortality in the group one, where patients successfully were weaned and extubated in first attempt was 5.3%, but in group two, where they took 3 days for weaning to happen or more than 3 days, it was 16.5, and there is 29.8% mortality where weaning took about 11 days. So there is a linear correlation with regards to outcome of the patient if the subsequent attempts in weaning has failed and if the weaning has exceeded to up to 7 days or more than 7 days, it has a linear correlation with mortality was what was shown in this study. Then there was another sort of a Japanese study which came with an eye criteria. So this came from the Japanese where they have looked at the predictors of weaning failure. So they have shown that if the patient is intubated in ICU for more than 24 hours, heart rate more than 110, or if someone has a renal dysfunction with blood urea more than 25 milligrams, and patient having acidemia, pH less than 7 points. So acidemia is an important factor which has been emphasized. So all the trainees can look into the acidosis as one of the indicators for the weaning failure. And they looked at the rise in the creatinine. This is also extremely important for all the trainees. So if a patient you are struggling to wean and there is a worsening acute kidney injury, or if there is a worsening pH. These are important indicators that you may have failure to wean. And this ITRAC criteria, if criteria is more than or equal to 4, then very likelihood that patient would need ventilator for more than 7 days and this becomes a difficult weaning. So here if you see, the three criteria are related to the kidney. So there is renal dysfunction, acidemia and creatinine more than 2 or 50% increase from the baseline. So the point that we are trying to make is patient in ICU, very likely they'll have acute kidney injury and they have worsening acute kidney. It's important signal to tell that these are the patients who may have difficulty in weaning and possibly they may go to the difficult weaning state of more than 7 days and possibly going ahead towards needing tracheostomy, so on and so forth. So this is a important sort of a signals that came out of this study. So ITRAC criteria is something you can keep in mind, which puts emphasis on AKI as a reason for delayed weaning. And sensitivity of this ITRAS criteria was sensitivity of 61.8 and specific, it had a good specificity of 82%. So, and as I said, patient has to be comfortable, compass mental, someone having anxiety, delirium, or someone with a huge cumulative positive balance with volume overload has shown to have a bearing on weaning difficulty, or someone who has a metabolic disorder like hypokalemia, hypo or hypernatremia, hypophosphatemia. So very important for trainees to look at the phosphate levels when you have a patient with difficulty to wean and again, if you see azotemia or renal dysfunction as put as an important marker for difficulty in weaning. So all of you bear in mind, AKI in ICU is not a simple thing. It has a bearing on difficult weaning. And AKI on dialysis has further uh, sort of a worse sort of a outcome with regards to weaning and the morbidity and mortality. So it's very important to emphasize on the fact someone having AKI has a very important bearing even on the weaning process. And most importantly, when there is difficulty in weaning, they have to be reassessed for cardiac dysfunction because someone having a low cardiac output state or severe diastolic dysfunction or LV systolic dysfunction has an important bearing on weaning, and that may be the reason for difficulty in weaning. So, very important if you have a patient who you are struggling, you have to reevaluate the cardiac status and determine if the cardiac status is okay, and because that may be also one of the contributing reasons. And of course, the respiratory failure and neuromuscular weakness, especially in patients, someone who is recovering from sepsis, septic shock. So you have to assess the strength of the muscles because neuromuscular weakness can be an important reason why there may be difficulty in weaning. So very briefly, we'll look into the studies comparing spontaneous breathing trial and pressure support. So this was a study that came from the French group where they looked at 109 patients comparing spontaneous breathing trial plus TPs with pressure support, and they saw the duration of weaning was significantly less when pressure support ventilation was used as opposed to TPs or intermittent mandatory ventilation. So based on the studies, the conclusions were intermittent mandatory ventilation is not recommended as a tool for weaning, and spontaneous breathing trial once a day could be tried as a separation attempt. If they succeed, nothing like it, that's the best. If they fail spontaneous breathing trial, then the suggestion or recommendation is to go on the supportive mode and slowly reduce the pressure support, correct the reversible cause, and reassess readiness to wean the next day. So this is a sort of a algorithm that is suggested. So there are multiple studies. I'll just take you through key studies which has compared spontaneous breathing trial with pressure support and with intermittent mandatory ventilation. So this came from this uh, Esteban group, which has done a lot of work on weaning, where when you look at the spontaneous breathing trial versus intermittent, so the relative risk of successful weaning was shown to be significantly better with spontaneous breathing trial. As you see, the relative risk was 2.83, and when they compared with pressure support also, SPT was found to be superior. And this is a study which again compared SPT with a control group, and they showed that the duration of ventilation was significantly less when SPT was used as a weaning mode, and the complication of respiratory failure also significantly less when SBT was used, and cost also was significantly less. So, but all the studies that have been done if you decipher. So when you compare TPs versus pressure support versus CPAP versus automatic tube compensation, there's no difference. So these are all different ways of spontaneous breathing style. Either you can put them on TPs, you can put them on pressure support, you can put them on CPAP or ATC. There is no difference with regards to outcome. So you can use any of these modes as a weaning, but intermittent mandatory ventilation not to be used as a weaning. But if a patient has for some reason endotracheal tube less than 7 millimeter, it is suggested that pressure support ventilation to be used as a weaning, gradual reduction of pressure support or automatic tube compensation, which is there in Puritan Bennett ventilator. So if you're using Puritan Bennett, you can use ATC, because when I was in Australia, we had Puritan Bennett and we used to use ATC as a weaning mode. So that is something you can keep in mind. So we'll just quickly jump gears. So very important aspect that we need to pay attention in the weaning is also the diaphragmatic fatigue that sets in. So what studies have shown is if they fail the first weaning attempt, then they've shown there is a significant diaphragmatic fatigue that happens. So the diaphragmatic, and it takes quite a few hours for the diaphragm to recover to its baseline. So, so that is why you see the suggestion. If they fail the first spontaneous breathing trial of 30 minutes to 2 hours, if they fail, then they say you have to rest the patient and do the weaning trial the next day, because it takes few hours for the diaphragm to recover to the baseline, because it would have got fatigue and it takes significant length of time to recover back to baseline. So this is important. So based on this, so we need to assess the diaphragmatic strength. And what has been shown is with every passing day on a ventilator, diaphragm undergoes atrophy, which leads to increased duration of mechanical ventilation, increased ICU length of stay, and increased complication rate. And in ICU, the diaphragm thickness also can come down, or it can increase due to a lot of edema, and this leads to increased risk of mechanical ventilation. And it is shown that in ICU, someone who is on a prolonged ventilator, the thickness reduces at a rate of 6 to 7.5% per day. The diaphragmatic thickness keeps coming down. And in children, this thickness reduction is little lesser. It's around 3.5% per day. So it is important. Now we have ultrasound tools. We need to assess the diaphragmatic strength or the diaphragmatic sort of a movement or excursion. So the three important variables one can look into diaphragm to ascertain readiness to wean. One is diaphragmatic exertion. The second one is time to peak inspiratory amplitude, which is called as TPI diaphragm. Then the third one is diaphragm thickness fraction of diaphragm. So there is a separate video on the way we assess the diaphragmatic weaning. So here I'll briefly tell the simplistic way is to look at the diaphragmatic exertion and peak inspiratory amplitude. So it's a very simple tool. So you can place the probe somewhere in the anterior axillary line and look at the diaphragm and put an M mode. So you look at the end inspiration and end expiration, you get a graph like this. So you take the measurement between inspiration and expiration. So the diaphragmatic excursion should be more than 10 millimeter. It's a very simplistic tool. Just place the cursor on the and visualize the diaphragm, put the M mode, and just assess the excursion. If it is more than 10 millimeter, it means diaphragmatic is functioning fine and there is readiness to wean. So it's a very simple test. So 13 millimeter is ideal, but if it is less than 10 millimeter, then very likely they may fail extubation. So, so I won't go into the details of the other peak inspiratory amplitude and thickness fraction. Thickness fraction of diaphragm should be more than 35 millimeter. So just look into these. There is a separate video on this. So there are studies done. Twans et al. 11 studies, 436 patients. 8 studies have looked at diaphragmatic excursion as a tool for weaning. 5 studies have looked at thickness fraction of diaphragmatic as a tool for weaning. And they showed both these tests have good diagnostic performance. And if there is diaphragmatic dysfunction, it is a clear indicator and a predictor of weaning failure. And as I said, diaphragmatic excursion, we expect it to be 11 to 14 millimeter. If it is less than 10, definitely they would fail the weaning. And thickness fraction of diaphragm should be somewhere between 30 to 36%. If it is less than 30%, it's a clear indicator of failure to wean. And this has increased sensitivity and specificity. And it is important where you have a patient more than 7 days, you have struggled to wean, diaphragm has to be assessed as a pre-extubation assessment. And we have done this in our practice, especially for neuromuscular weakness like myasthenia gravis, and we have found it to be very useful. So it's a very simple test that can be done. So then we'll move to if you are struggling to wean a patient, is there a possibility of extubation to NIV? So this was a study, again, a Cochrane review database, which looked into meta-analysis of 12 randomized controlled trials, 530 patients. If they have failed SPT, where 7 days you have struggled, and but they fulfill all criteria for other extubation. Could extubation to NIV lead to success? They have shown failed XBT, extubation to NIV, they showed that mortality could be reduced, the risk of VAP was reduced, but duration of mechanical ventilation, tracheostomy, and reintubation, there was no statistical significance, but they did show reduction of VAP and mortality. And conclusions they made is extubation to NIV could be considered, especially in patients with COPD, because COPD patients uh, not necessarily may fulfill all the criteria, and sometimes they do appear tachypnic. So this is one category where extubation to NIV can be tried, but this should be avoided where you may have a patient with difficult airway, or patient has a poor cough, or patient has impaired mental status, or in patient who has increased secretions who may have difficulty in expectorating. These are the patients where this should be avoided. It could be considered in COPD if they fulfill the checklist. And this is the category of patients where we may have success with extubation to NIV. So how about weaning protocols? So the evidence has clearly pointed out that every ICU should have a weaning protocol in place to improve the outcomes in the patients. So the weaning protocol should encompass readiness to wean and the process of weaning trial. And multiple studies have shown having weaning protocol is mandatory and it is shown to be beneficial. So this is a study, again a meta-analysis which was published in BMJ, 11 randomized controlled trials, 1,971 patients, where they shown having a weaning protocol reduces the duration of mechanical ventilation by 25%. But having this weaning protocol showed no benefit, especially in a closed ICU where intensivists are directing the care. So if you are running a very closed ICU, because intensivist is so much involved and committed to the care, it may not make a difference. But if the ICU is a very busy and it is sort of a multidisciplinary ICU, so having weaning protocol is a good way to ensure that some weaning process is happening in your ventilated patients. And as I said, the quality benchmark is more than 55% of your ventilated patients should be assessed for the weaning trial and should be put on a process of weaning protocol in an ICU. That's a quality indicator. So there's something called automated weaning. I'm sure you have heard of ventilatory modes like proportional assist ventilation, adaptive support ventilation, where ventilator adjusts the level of pressure support based on the patient's respiratory rate, patient's tidal volume, and carbon dioxide. The ventilator does its own pressure support adjustment based on the respiratory rate, tidal volume, and carbon dioxide, and it starts reducing the pressure support. So there was study, again a Cochrane review database published by Canadian group in 2014, 21 randomized controlled trials, 1607, where they showed automatic weaning reduced the duration of mechanical ventilation by 10%, reduced ICU length of stay by 8%, but there was no difference on mortality, and benefit was seen only in medical patients, and there was no harmful effects. So limitations is they had heterogeneous group of patients, and this automated weaning is not applicable to pediatric or in COPD patients where CO2 was more than 60. So if you have proportional assist ventilation or adaptive support, you could use this also as a mode of weaning, where you don't have to keep tweaking manually. So ventilator is assessing every breath and is doing it auto adjustment of pressure. So that's about a brief overview. So summary and recommendation is, so the whole process of weaning is reducing the support to the patient with regards to the ventilator effort that is offered. So when we talk about weaning, we talk about spontaneous breathing trial, which could be TPs, which could be lowering the pressure support, gradual lowering, or putting patient on a CPAP or automatic tube compensation if you are dealing with Puritan Bennett ventilator. For endotracheal tube less than 7 millimeter, the suggestion and recommendation is to gradually lower the pressure support rather than putting them on TPs or ATC or CPAP. And readiness, or once they are ready for weaning, once a day SPT could be tried, and that gets grade 2B recommendation. And the once a day weaning can vary from 30 minutes to 2 hours. And if patient is mechanically ventilated for more than 10 days and they have failed weaning trials, sometimes the suggestion is you can extend this weaning period up to 120 minutes, which is 2 hours. So your weaning period can be 30 minutes to 120 minutes, and you increase the weaning period, especially in someone with a prolonged ventilation, where you may have to be absolutely sure if they're able to breathe comfortably for 2 hours. If it is less than 3 days and all, 30 minutes of HBT may be good enough to tell you that patient can be extubated. And if if they tolerate 120 minutes of comfortable breathing without getting tachypneic or without hemodynamic instability or without distress, patient can be extubated. If they fail even after 120 minutes, then the suggestion is that possibly you have to think of alternative, that they may need tracheostomy if ventilation is gone to more than 10 days. Or one could consider progressive reduction in prayer support, but intermittent mandatory ventilation alone is not recommended. And that is grade 1B. It is a strong recommendation that intermittent mandatory ventilation not to be used as a weaning protocol. And it is suggested to have a protocol, weaning protocol, especially in open ICU, and that gets a strong recommendation with moderate evidence. In closed ICU also it is helpful, but the recommendation is little underwhelmed in closed ICU. So this is in brief about the weaning protocol, and this is the structure indicator. As I said, having a weaning protocol is a structure indicator, and as you see, the quality benchmark as a stand is 55%, and the formula uses number of mechanical ventilation patients with daily spontaneous breathing trials divided by total number of mechanical ventilated patients into 100. That's the formula you use to determine that at least more than 55% of your intubated patients should be put every day on some sort of a weaning protocol or a weaning process, and that is a quality indicator that one has to adopt. So thank you one and all. So I request all of you to submit your valuable work to Journal of Acute Care, which comes out every 3 months, and you can visit my website www.drpradeeprangappa.com to read to this lecture. So that's a brief overview. So there are multiple studies comparing SBT. I've shown you only the major studies and the general approach to the whole weaning. So you can, for all the trainings, you can remember the wind criteria, which seems to be more accepted, and that has really given us conviction that delayed weaning. I think the take-home message is that delayed weaning has a linear sequential bearing on the outcome and on the mortality also. So the longer you have a patient where you struggle to wean, it has a bearing on morbidity and mortality. And what we could see in the recent studies is renal dysfunction plays an important role in the delayed weaning. Because if you look at the ITRAC criteria, acidosis, increase in the creatinine, and renal dysfunction forms the criteria, and that forms 3 out of 5 criteria as the indicators of difficult weaning. I think these are the few newer messages that have come out from the recent study. So thank you one and all.